Hello, my name is Paul Watson. I'm a lecturer at Northumbria University in mental health and school nursing. I'm also a PhD candidate, and my PhD is looking at young carers of veterans with mental health issues, particularly PTSD. My PhD is underpinned from a theoretical framework of symbolic interactionism. And it's an ontological assumption based on the belief that reality is socially constructed, and an emic epistemology built on subjective lived experience using narrative inquiry. Using symbolic interactionism as an ontological approach to understanding the perceptions of one's truth, as described by Mead, is built on what we believe to be true, and is based on how we and others communicate what we believe are those truths. Therefore, one could argue reality is constructed by observations, interpretations, perceptions, and our conclusions, which are established by shared narratives. Therefore, investigating interactions and the consequences of those interactions. Emic epistemology, an insider's view of reality, is one of the principal concepts which guide qualitative research and my PhD. An emic perspective is fundamental to understanding how people perceive the world around them. Moreover, adapting an emic perspective allows the multiple realities, variations of knowledge, resulting in numerous interpretations of the lived experience which exists within this specific culture. And importantly, is determined by local custom, meaning, and belief, which is best described by a native of the culture. Being a cultural insider myself has enabled me to really understand the cultural aspect of military life and being a young carer within the military community. Why inquiring into the narratives are important in truly understanding the lived experience. To understand what it is to be a young carer from a military family, we must hear the voice of the young carer. When we capture this voice, what are we doing with it? We have two options. We can use the narratives captured and analyze the individual or collectives to understand the themes from the told stories. This process allows for stories to be used as data in helping shape temporality within the young carer's life, which in turn will help capture sensitive periods, changes in role, change in presentation, adaptations within their lives, and the effects caring has, be that positive or negative. Essentially, we get a whole picture of the young carer's life course. However, if we then inquire into the captured narratives, we can interpret and assign meaning. Inquiring into the narratives of the lived experience of a young carer of a veteran with PTSD will provide a subjective insight into the meaning of the words they are sharing. Therefore, meanings are modified based on the individual's interpretation of the narrator or researcher. For example, the term young carer is a socially constructed label based on a given role within the family dynamic by health and social care professionals. Moreover, importantly, the term young carer may also hold a different meaning to the individual, which may go some way as to explain the difficulty in recruiting a young person who is yet to know they are a young carer. Importantly, defining the label or symbolic meaning of being a young carer within the concepts of symbolic interactionism's traditions, the goal for my PhD is to give understanding to the complex world of the lived experience of being a young carer of a veteran with PTSD, and unveil an insider's view of their reality. The use of narrative inquiry within my research is orientated towards producing an understanding of the young carer's experience of living with a parent with PTSD, who is also a military veteran. Exploring how this experience affects their emotional health and how caring affects the young carer's activities of daily living. As Phoenix, Smith and Sparks explain, narratives are form of inquiry suited to exploring the lived experience of others. due to narratives being a process which people use to make sense of their life's journey. Being a young carer of a veteran with PTSD. As a young carer of a veteran myself, I lived with a very similar life to many of the young carers within my research, and possibly more young carers from the military community and beyond. You'll notice from the following story of my life, if you record and present my narratives, you will be able to produce structural context over time and see themes which are emerging throughout my whole life, from being a child, a young person, then transitioning into a young carer. However, if we look at the words spoken, we can inquire into what those words mean and apply theory to them to help understand their meaning further. I was born in Manchester and I grew up in a council estate in Glossop. I wasn't a military child at that point. My mum and dad separated. I was then shared between my mother and my father. My mum met my then to be stepfather, who was in the military and was soon to be posted to Germany. This relationship was quite quick, and by the time I was 4, I was living in Germany. Being a military child was something that I did enjoy. There was friends on tap. Schools were good, but there was a lot of cultural differences that I noticed. There was a lot of drinking. There was some domestic violence within my household, and I think it wasn't until I was maybe 10 that my stepfather went to the first Gulf War, and that when he come back, there was a total change in his presentation. He was drinking more. There was considerable domestic violence. He turned to gambling, and it just became really difficult. And I was quite scared of the person that he had become, which kind of changed the dynamic. But my mum was working 3 or 4 jobs to help with the bills because of the gambling, and I was providing care for my brother. I was pretty much looking after my younger brother, who is 6.5 years younger than me. I was also providing emotional care for my mum because of the strains of what was going on, and it kind of came to a head once at one point where there was significant domestic violence and the police came, and I think from then life changed. They separated, and we moved on. But I think the effects of that, have followed me throughout my adolescence and my adulthood, due to some of the sights that I've seen throughout my childhood, and they did have a negative effect on me. And I've always been searching for something, which I didn't know what it was until I found my wife. To be fair, but I think when we look at a young carer's life of a veteran with PTSD, it's complex and it's hard, and it does have lasting effects. But as you can tell from my narrative, there's a whole life story, a start, a middle, and an end. But if you picked up some of the words or the sentences, for example, I felt scared, especially when it was quiet. In its simplest form, I'm describing an action. I went scared when the house went silent. However, if we break this down, we're looking at a time frame. When it went quiet, we were also seeing a product of time, feeling scared. Therefore, we have an action and a consequence of that action. This inquiring into the narrative of the lived experience. So what happens if we don't engage children in research? As noted in the current slides, there are a number of studies which offer the perspectives due to the difficulty in ethical application and multiple reasons why access to this unique population is difficult. Therefore, if we don't hear the voice from this population, we will continually get the perceptions of others who may be witnessing the acts or the emotions from the young carers of veterans with PTSD without truly inquiring into the life of that young carer. Children's rights to be part of the research is fundamental. Research with children is acceptable and entirely valid where the research question posed is important to the health and well-being of the child or the children, or in this case the young carers. The perception of children in this study is essential in capturing their experience of family life prior to and after caring. Article 12 of the United Nations Convention on Rights of the Child states that a child who is capable of forming his or her own views should have the right to express their views freely on all matters affecting the child. And those views should be given weight in accordance with age and maturity. Therefore, it is important for those carrying out research on children, young people and young carers to continually reflect on the power imbalance in the processes of research when conducting research with children and young people and young carers, which as a cultural insider is a continual battle and something I continually have to reflect on. Empowering children to consent to take part in research freely without coercion, threat or persuasion, even if a gatekeeper has provided consent, acknowledging the child as an expert in their own life and promoting autonomy whilst validating their narratives regarding being a young carer is vital. So why inquiring into the voice of young carers is important? When we look into the short narrative within the slide, we can see an overall picture of what is going on for that young carer in a moment of time. And we can see themes from within each text. For example, the first one reads, I miss him a lot. Something is missing at home. We have a big house. And when someone is missing, it's like empty. This describes a parent being away. But when we inquire into the narratives, we can see the feelings and the emotions behind the parent being away. Therefore, we find meaning to the context of that moment in that young carer's life. The third extract provides something more. I try to help my dad, but he keeps pushing me away. So I feel I am doing wrong. Here we can see a young carer being pushed away when they're trying to support their father. When we inquire into the narrative, we can see the actions, reactions are rejection, which makes the young carer feel they are wrong. If we add a theory or context trying to help and being rejected, we might look at attachment theory and its association with a secure base. However, when we look at it from a symbolic interactionism position, we can see the symbol. The dad has changed and he's now rejecting his child. Therefore, the symbolic meaning of dad changes and the child becomes hesitant to provide interaction for fear of being rejection. Therefore, meaning between the interaction and outcome changes. For instance, if I try and I help my father, will I get pushed away? Which was different prior to Afghanistan. When I try and help, I get praised and we have fun. I would like to introduce one of the young carers within my study. And whilst I introduce this young carer, I'd like you to just kind of read what's going on and look at the narrative analysis within there. Okay. So this young carer is 14 years old and whose parents split up when they were young, when she was younger. She doesn't really kind of know her father, and then her mum started a relationship with a veteran who served in the armed forces, obviously, but seen some things in combat which was horrific, and subsequently was diagnosed with PTSD. Okay, so you can see from narrative analysis there is a start, a middle and an end, offering temporality in this young carer's life. However, when we inquire into the narratives, we can see a number of meanings which, when extracted from the data, leads to pertinent theoretical text. For example, when the young carer describes a presentation of PTSD, her actions change and she becomes a protector of her brothers, but also her mum, due to domestic violence. Acting as a protector as a child or a young person has the capability to change the wiring within our neurotransmitters. There becomes a presentation of being on high alert and trying to anticipate and forecast, as described as walking on eggshells. Living with domestic violence, girls are more likely to keep their distress inside. They become withdrawn from other people and become anxious or depressed. They may think badly of themselves and complain of vague physical symptoms. They are more likely to have an eating disorder or to harm themselves by taking overdoses or cutting themselves. They are also more likely to choose an abusive partner themselves. Children of any age can develop symptoms of what's called post-traumatic stress disorder. They may get nightmares, flashbacks, become very jumpy, and have headaches and physical pains. We are able then to add contextual meaning when we understand the inquired narratives of the young carer and the physical and emotional effects caring has on this young carer. Moreover, we can apply the science behind the role of this young carer and provide appropriate and timely support and intervention. So, a second participant within my research, he is a sibling and his sister was part of the research as well. Now, this young person has a really good relationship with their dad, and during kind of Afghanistan, his father was injured and was brought back to the Queen Elizabeth Hospital in Birmingham. The children couldn't attend, and this caused significant anxiety and stress for both children within the homes. Then his father went back to Afghanistan for a second and third time, and due to the experiences of his father being injured the first time, there was heightened anxiety of whether they were going to get a knock on the door or whether the phone rang, if they were potentially to think about whether his father was injured again or worse, had passed away. But when we look at these narratives again, okay, and when we inquire into this young carer's narratives, we can see a number of meanings due to the change in presentation of his father, and the symbol of his dad changes to something to avoid opposed to interact with, which we can see from the first extract, a solid relationship. Importantly, when we inquire into the fourth extract, we can see that presentation of the father is something this young carer has become used to. When we apply theory to this sentence, we can utilize the works of Dr. Burke Harris, who articulates the body stress response is regulated by the hypothalamic pituitary adrenal axis, or the HPA axis. When the body receives a threat or stress, the brain signals the hypodermis, which releases hormones that trigger the pituitary gland. This pituitary gland then releases a different hormone that stimulates an adrenaline gland to produce adrenaline and cortisol. The example Dr. Burke shares within her TED Talks and her writings are as follows. Imagine that you're walking through the woods and suddenly you come across an angry bear. Your natural instinct is to run away from the danger. Within your body, you release a series of hormones that govern your response to stress. It is this hormonal process that triggers the innate reaction to fight or flight when you're in danger. When the body reacts to a threat or stressor, in this case the angry bear in your path, the brain triggers a series of hormone releases that activate the production of adrenaline and cortisol. Adrenaline is a hormone that is central to the body's short-term response to stress, increasing the body's heart rate and causing pulse dilation so the body is better equipped to combat the threat. Cortisol is a critical hormone in the body's long-term response to stress, increasing blood pressure and blood sugar to regulate the body's metabolism and immune response. Now imagine that angry bear is a regular occurrence on your walk home, but you never know if you're going to see him or not. So every day your body is producing cortisol to make sure that you are ready to run away in case you see the angry bear. Your body's stress response systems is chronically activated. Your bodies are not meant to be in a state of constant stress response. As characterized by the term fight or flight, the body's stress response developed as a response to short periodic threats. Over time, this strong, frequent, or chronic stress can lead to the dysregulation of the body's stress response system, meaning that the system responds in an unhealthy way and sometimes producing inappropriate amounts of cortisol, sometimes responding to small or inappropriate threats. This is potentially the young carer's body living in toxic stress. So when we analyze the narratives, what we see from the two young carers within this presentation is a temporal shift in their life course. We see their once stable and affectionate relationship with their father prior to Afghanistan change over time due to the presence of PTSD and the symptomology of its presentation. Moreover, we see their home environment change from something which is full of love, affection, and safety turn into a place where they hide away, isolate themselves, protect and support others, and become hypervigilant, preparing for a potential emotional attack or toxic stress. The narratives then move to a place where there is an acceptance and engagement in services for those with PTSD. This positive intervention really shifts the course of the narratives among all the young carers. They describe having a diagnosis and by providing a caring role has seen a shift in their relationship with their fathers. It is worth noting, none of the participants classed themselves as a young carer. However, during the interviews, they could identify their roles in which they undertook out of love. It was great to see through providing care, the young carers had established connections with their father, albeit very different to the one they had pre-Afghanistan. When we inquire into the narratives and its findings, many things come out. We look at adverse childhood experiences. First published in 1998, the Adverse Child Experience Study was a simple but profound study that revolutionized how we understood the relationship between childhood and long-term health of adults. The result of the ACE study was astonishing. Almost 2/3 of participants reported having one or more childhood adverse experiences. 1 in 8 participants reported having 4 or more ACEs. The most commonly reported ACE was physical abuse, substance abuse by a household member, and parental separation or divorce. And being a military family, whilst the ACE study does kind of allude to separation being moving away from your family or your parents separating, I think what we have is something quite unique in the terms that we often are separated from our family members due to service. And I think that's a really good pertinent point that we have to note and take account for when we're looking at adversities in childhood. Even more alarming, research found strong correlations between ACEs and poor health outcomes among participants. Research found increased risk of disease and negative health behaviours. When we look at inquiring into the narratives of these young carers of veterans with PTSD, we can see a number of adverse childhood experiences. Whilst not wanting to pathologize or medicalize being a young carer, I feel it is important that we understand their narratives of vocalizing a number of adverse experience, which in turn creates meaning. What does this mean for young carers of veterans with PTSD? Neglect. The inquired narratives demonstrate when a parent presents with PTSD, they're not emotionally connected to their child. The young carer reports not connecting emotionally, feeling isolated, and explain feeling of rejection of affection from their fathers. Home dysfunction, living with parental PTSD, domestic violence, substance abuse, and for some, divorce. again, we have that constant separation due to service. Therefore, it is important to understand the effects of caring for a veteran with PTSD due to the short, medium, and long-term psychological and physical effects of adversity in childhood, along with some of the well-explored negative effects of providing care as a young person. At this point, my presentation is finished, but I really would like to thank you all for listening. But more importantly, I'd really like to thank you for doing what you do, wanting to support young carers and young carers from military families to create positive outcomes. But I think when we look at inquiring into those narratives, we can see so much more of that young carer and what that means to the context of the theory in which we can add to help shape service provision and more research. But I think fundamentally it is about hearing that voice and not just hearing it for the purpose of hearing it. It's taking action on specifics within that voice. Thank you.